A very good morning to you. My name is Arosh Sanak. I'm the president of the Ceylon College of Physicians. A warm welcome to all of you for this specialty update, which the CCP is having in collaboration with the Sri Lanka Association of Geriatric Medicine. As you all are well aware, CCP has a continuing specialty update program where each month is assigned a theme. And over the past 1 year, we are approaching the end of the year. Over the past, this is the 10th month of the year, other than the month of September, where we had the annual academic sessions. Every month has had a theme. And this month of October, the theme is care of the elderly or geriatric medicine. We've already had one or two other activities related to that. We had the college lecture delivered by Dr. Shehan Silva. And then we had cutting edge lecture, which is looking at the latest developments in a particular field, delivered by Dr. Duncan Forsyth. Both of these, if you missed, are available on the CCP YouTube channel, as well as the links are available on the Facebook page. So you can go and listen. Both of those were outstanding lectures. And this is the third activity for the month of October. And we have today 4 eminent speakers with a clinical and a research interest in geriatric medicine who will be speaking to you today. And then, of course, the fourth activity will be the quiz. There is always a quiz every month, CCP quiz, and then there will be a quiz on the contents of these lectures. And those who do best within, we open the quiz for a few hours, and then we time how long they take to answer the quiz. And then those who can answer the quiz within the shortest possible time, the highest possible marks, will get a prize from the CCP as well. So those are the 4 activities, and we are on to the third activity. It is my great pleasure to welcome the speakers as well as the audience. Now, it is my very pleasant task. And also just one more little thing that I want to add, that is the Association of Geriatric Medicine and CCP has been very closely intertwined, because some of the CCP past presidents have gone on to become the president of the Association of Geriatric Medicine. In the past, I think Professor Sarath Lekamwasam and Dr. Padma Gunaratna were presidents of this association. There may have been others whom I have missed, but I wish to thank especially Professor Kamani Vanigasuriya, who is the current president of the Association of Geriatric Medicine, again another past president of the CCP, as well as the council, which again constitutes some very prominent members of the CCP, who contributed immensely to the CCP's activities. So I thank all of them for helping arrange this session. And it's my great pleasure to hand over to Dr. Dilha Samarvira, my very dear friend and colleague in the CCP as well, to explain a little bit about the Association of Geriatric Medicine and its link with the CCP and how it sees its future. Over to you, Dilha.
Yeah, thank you very much, Arosha. So very good morning to all of you. So I welcome all of you to the specialty update on geriatric medicine. And as Arosha mentioned, for many years, we have been collaborating with the CCP to conduct this specialty update. And I actually was the founder president of the Sri Lankan Geriatric Association of Sri Lankan Association of Geriatric Medicine. So we started this program with the CCP, and we have been continuing this for many years. And we have contributed with the resource persons for these lectures. So today we have 4 eminent speakers who will speak to you on various aspects of geriatric medicine. And you already know, probably for those of who don't know about the specialty, we have a diploma in geriatric medicine, and also now we have a MD in geriatric medicine, and we have already produced about 6 to 8 geriatricians in the country. So all of them will be coming back, and then we'll speak to you and we'll develop this specialty. So on behalf of the Sri Lanka Geriatric Association, I wish to thank Professor Arosha, the President of the CCP and the Council of the CCP, all co-speakers and the participants, and best wishes for a successful program. Thank you.
Good morning to you all. I'm Dr. Hirantini here. I will be moderating this session. So we have very important topics lined up for you this morning. The first speaker today is Dr. Dilusha Lama Badusurya. She's a specialist in internal medicine and visiting lecturer at the Kotalavala Defense University Hospital. So we know that the high prevalence of disease states in older people means they take many medicines. Dr. Lama Badusurya will be talking to us on polypharmacy, when less is more. This is a pre-recorded lecture. A kind reminder, you will need to send in your questions on the Q&A, and Dr. Shehan Silva will answer any questions if you have. Thank you. So we'll be starting the pre-recorded lecture now.
Good morning, everybody. Firstly, may I thank the Ceylon College of Physicians and the Sri Lanka Association of Geriatric Medicine for giving me the opportunity to participate in the specialty update this month. And I do apologize for not being able to join in with the session live. I will be talking about polypharmacy, when less is more. Let me begin my presentation with a story. So this is a story of a 76-year-old lady who's brought into the emergency treatment unit following a fall with pain in her right hip joint. She is clinically suspected to have a fracture, and the X-ray of the hip joint confirms this. She goes on to have surgery, but her post-op period is unfortunately complicated with orthostatic pneumonia, a DVT, and finally, unfortunately, she succumbs to these illnesses. When we look back as to why she fell, because it was the fall that triggered all of these events, a story unfolds. So this lady had a past medical history of hypertension, diabetes, asthma, hypothyroidism, osteoarthritis, and a minor stroke. 4 months before her fall, she was diagnosed to have hypertension, and her GP starts her on amlodipine. She does quite well with this medication, but she notices that her legs are getting progressively swollen, and her family take her to a cardiologist who starts her on furosemide. This reduces her edema, but she notices now that she has very troublesome bladder symptoms. She has frequency of micturition and in fact sometimes suffers from urge incontinence. Once again, her family take her to a urologist who prescribes tolterodine for an overactive bladder. During the next few weeks, her mobility progressively worsens. She's prone to falling. She becomes dizzy often and becomes progressively confused. And finally, one day she falls, resulting in this fracture, and is brought into hospital. On the assessment done at admission, she is found to have a significant postural drop in her blood pressure. The sodium is 120, and she is quite confused. So unfortunately, a cascade of events led to this. And it is very likely to be due to her changes in her medications. So what is polypharmacy? Polypharmacy is arbitrarily defined as a patient that is on 5 or more medications, be it conventional or over-the-counter or homeopathic medications. This could be an entirely appropriate prescription because we know there are patients with multiple comorbidities with definite indications for several different drugs. But it could also be a problematic polypharmacy where the indications are not clear, there are significant interdrug interactions and significant patient-drug interactions. Why is polypharmacy particularly a problem of the elderly? As we know, the elderly have multiple comorbidities, resulting in multiple drugs being prescribed. They are also more prone to be self-medicating, particularly with over-the-counter drugs for symptomatic relief. And due to the multiple morbidity, it is often, particularly in the local context, that they would be seeing multiple physicians and subspecialists. And there is, due to poor record keeping, a lack of therapeutic reconciliation. And prescribing in elderly is definitely a challenge. We don't know how these drugs act in the elderly age groups because most of the pre-marketing trials are not done on geriatric groups. So we only have the real world data. The age-related changes in pharmacokinetics and dynamics, which I won't go into detail here, pose a lot of challenges because the drugs are handled differently in the body by the elderly, in the bodies of the elderly. There are differences in drug doses that can be used due to increased volumes of distribution and decreased drug clearance. This all leads to multiple drug interactions, and socioeconomic factors also play a key role. So what are the potential consequences of polypharmacy in the elderly? One key thing is higher propensity for adverse drug reactions. GI bleeds, postural hypotension, falls and fractures, as in the case of the lady we talked about earlier, cognitive impairment, and renal injury, all resulting in increased morbidity, hospitalizations, increased mortality, and of course, increased healthcare costs. It also leads to prescribing cascades. A prescribing cascade is a situation in which a first drug is administered to a patient and that causes an adverse event or a sign or a symptom. And this is interpreted as a new condition and a new medication is prescribed to combat that. This sets off a cascade of prescriptions. I have put here some common cascades that can occur. I'll highlight a few. Prescription of non-steroidal anti-inflammatory drugs for aches and pains can lead to fluid retention and a secondary hypertensive state, and we prescribe antihypertensive medication for that. However, the use of the NSAID is transient, but the antihypertensive medication continues and causes problems in the patient. Another common cascade is the use of antipsychotics leading to Parkinsonism and anti-Parkinson's medication. Of course, some of these prescriptions may be unavoidable, but some could be rectified, and I will detail that later. So in order to identify which patients, we see large volumes of patients, it's difficult to apply this to each and every patient that we see. We have some tools to identify which patients are potentially are using inappropriate medication. And there are several screening methods for that. The American Geriatric Society's Beers criteria it talks about 5 categories of medication and it lists 88 classes of drugs in total. There are medications that are potentially inappropriate, medications that should be used with caution, the drug-drug interactions that should be avoided, and the ones that should be reduced, doses should be reduced due to varying kidney functions. The limitations of the Beers criteria is that they don't talk about under-prescribed medications at all. That is the medications that these patients should be on. They also don't offer alternative medications, and this is not validated outside of America. The stop and start criteria is another tool that is used quite commonly, even in Sri Lanka. This talks about 8 inappropriate medications and 34 under-prescribed medications and is organized according to the organ system, adverse events, and other drug classes such as vaccines. This again doesn't offer any alternatives and doesn't talk about renal dose adjustments. A group in Sri Jawaharlal University, in fact, has modified the stop-start criteria and published this paper as well to modify it for use in Sri Lanka. because the use of the generic stop-start criteria in Sri Lanka is being proven to be quite problematic due to some medications in that list not being even registered or used in Sri Lanka, and due to the poor record keeping. So they have used a modified stop-start with 70 stop criteria and 35 start criteria. And this is in the process of being validated through a multi-center trial. Other tools that can be used for validation include, other tools that can be used for screening include the FOTA and Eurofota criteria. But it is important to remember that tools are merely a screening method. They are for us to identify and streamline vulnerable patients and bring them to to the attention of specialists and for us to pay more attention to them. And in the end, it is our clinical judgment that we use to adjust patients' prescriptions. We also want to talk a bit about the anticholinergic burden here. So this is becoming a recognized problem, and more attention is being paid to it in the recent few years. Apart from the conventional anticholinergic medications, it is now known that other medications also have anticholinergic action. And in a prescription, the action of this can accumulate, causing significant problems. So they develop all the side effects of anticholinergic medications, such as confusion, hallucinations, dry mouth, constipation, visual disturbances, urinary problems. And in a younger patient, something like the dry mouth or constipation may not be so problematic, but in the elderly, especially with all of this accumulating, it can cause significant morbidity. It falls, cognitive impairment, increased hospitalization, and we know all of that leads to increased mortality. So various risk scales have been developed. I took this from up to date about grading drugs according to their risk of anticholinergic effects. So apart from what we know as anticholinergic drugs, such as atropine or benztropine, you'll be surprised to know something like even like chlorpheniramine has scores 3 points on the anticholinergic risk scale. So the higher the number of points, the higher the risk of anticholinergic side effects. And you can see how these points can accumulate, or the risk can accumulate in a single prescription. So if a patient is on chlorpheniramine, loperamide, say for pulmonary diarrhea, and ranitidine, or he is scoring 6 points just there with significant anticholinergic risk. So this is, in fact, there are anticholinergic burden calculators that are used commonly in geriatric wards overseas, where they put the prescription in this calculator, see which medication is scoring the most, and see if any alternatives with a lower risk score can be used, so that patients' anticholinergic burdens can be reduced. So once we do use our screening tools and identify patients at risk of inappropriate medications or at risk of polypharmacy, we need to pay careful attention as to how we are going to modify their current medication. So I think the first step would be to do a thorough therapeutic reconciliation. Quite often in our patients, they have multiple prescriptions from multiple different specialists. They have been having several hospital stays with medications changing from each of those hospital stays. And the patient himself may have the prescription, but is not taking those medications or self-medicating. So a careful and thorough therapeutic reconciliation needs to be done, as time-consuming as it may be, to find out exactly what the patient has been on in the last few months. Once we know what the prescription is, then we look at what the drugs are and is there a clear indication for that drug to be used in this patient. It may be that there was an indication for that medication 5 years ago. It may be that that indication doesn't exist any longer, or that it is not relevant to that patient anymore because of his age, because of his comorbidities, because of his frailty state. So each and every medication should be reviewed to see if there's an indication that is still existing for it, or whether that indication is relevant. If we decide that neither of these is a yes, the answer to either of these is a yes, then we have to consider stopping this medication. And it is important to keep in mind certain medication has to be tapered off to reduce any withdrawal reactions, otherwise this will create problems as well. If the medication has to be continued, there is indication for it, then we look to see if it can be substituted with a potentially safer agent with less side effects, with less interactions. And if a different agent or the same agent has to be used, we can see if we need to change the dose of the drug. What is the patient's EGFR? Does the dose need a renal adjustment? And also, are we using the minimally effective dose, thereby reducing the potential side effects? And perhaps the most important thing I'm mentioning last is always to consider non-pharmacological methods of managing symptoms and signs, as well as diseases in these patients before we jump to medication. And the prime example for this is problems in sleep insomnia, where we very often jump to prescribing hypnotics without looking at sleep hygiene and taking the patient through sleep hygiene rules. Pardon me. So this is a flow chart of a medication review I have obtained from UpToDate, which kind of summarizes what I mentioned before. So you do a therapeutic reconciliation and get the list of medication the patient is on, and look at the indication. If there's a clear indication given the patient's age, disability level now, and if the benefit is outweighing the adverse effects, if the answer is yes to all of them, yes, that's fine, you continue the same dose. If you are not sure about the answer to those questions, then you reassess whether the indication is still valid and relevant to this patient's age group and disability. If it is no, you stop the drug. If it is yes, there is an indication for it, you still have to assess whether the benefit of this in this frail patient outweighs the adverse effects or the risks of taking the drug. So even if there is an indication and there is a benefit of the drug, if there is more adverse, if the balance is tipped towards more the adverse reactions of the drug, you would still stop the drug or consider shifting to another drug or reducing the dose of the same drug. So in this way, we can modify the prescriptions of the elderly to reduce the impact of polypharmacy. I would like to finish my presentation by keeping you with these three take-home messages. Remember that polypharmacy can be as dangerous as any other condition in the elderly, even resulting in death. And perhaps we should take this as seriously as a elderly patient coming in with a myocardial infarction, a stroke, or a fracture. Periodic evaluation of medication is an essential part of caring for an elderly patient. And please make it an opportunity at every setting to do this, be it in a clinic or a patient coming just admitting with a UTI to the hospital or to your ward. Make it an opportunity to do this. And always take a holistic approach, an individualized approach, taking the patient's wishes into account, then modifying their prescriptions to reduce the impact of polypharmacy. Thank you. These are the references that I used for my talk. And I thank you very much again, and finish here.
Thank you. We want to thank Dr. Lama Madhusurya for that very practical talk on polypharmacy and the issues in the care of the elderly. In the absence of questions, we will move on to the next lecture. Before we move on, we will be presenting an e-certificate of appreciation, and you will receive it in due course. Thank you. So the next speaker for today is Dr. Anuprabha Wickramasinghe, consultant psychiatrist and senior lecturer in psychiatry of the Faculty of Medicine, University of Colombo. Her topic is a holistic look at behavioral and psychological symptoms of dementia. Over to you, Dr. Anuprabha.
Hello, can you hear me? Can you hear me?
Yes, yes, we can hear you.
All right, okay. Good morning, everybody. Today I'm going to talk about behavioral and psychological symptoms of dementia. This is the layout of my talk. Right. So even the earliest descriptions of dementia had the neuropsychiatric manifestations described, like delusions and hallucinations. However, the current emphasis on cognitive symptoms, especially in making diagnosis, distracts us from the fact that neuropsychiatric manifestations are very common and at least equally troublesome. About 90% of the patients are affected by at least one of the neuropsychiatric manifestations during the course of their illness. And to complicate the matter more, there's very little evidence-based treatment to address neuropsychiatric manifestations. They can simply be classified into three groups: psychotic, mood, and activity related. And there are some approximate prevalences given in this chart. Hallucinations are about 20 to 30% of the roughly has a prevalence of 20 to 30%. Paranoid delusions and delusional thoughts, another 20 to 30%. Misidentification syndromes, 10 to 20%. Then when it comes to depression, prevalence would be 10 to 25%. Mania, quite rare, less than 5%. Anxiety could be more than 50%. In active common, aggression 20 to 40%, and circadian rhythm disturbances 30 to 80%. This graph actually shows point prevalence of neuropsychiatric symptoms at baseline and at 4 follow-up points. As you can see, they usually tend to increase with the disease progression, especially if you look at depression, apathy, and anxiety. They tend to steadily get worse. There are other symptoms like delusions, hallucinations, disinhibition, aggression. They have a more episodic course. This is the same study, a Cache County study, very famous study from 2008, showing period prevalence of these symptoms. And at the end of 5 years, up to about 97% of people had at least one symptoms of BPSD. So, does the type of dementia predict the development of certain BPSD symptoms? Actually, there are evidence to say that certain dementias give rise to a certain pattern of BPSD. We know a frontotemporal dementia affects executive control and leads to disinhibition, wandering, social inappropriateness, and apathy. Psychosis is more common in Lewy body dementias, which is dementias with Lewy bodies and Parkinson's disease dementia together. And also they are common in Alzheimer's dementia. Out of those conditions, hallucinations are more common in Lewy body dementia when compared to Alzheimer's. Compared to vascular dementia, hallucinations, delusions, anxiety are commoner in Alzheimer's or mixed dementias. In vascular dementia, agitation, depression, and disinhibition are more common when compared to Alzheimer's dementia. So you can see there are some patterns in these BPSD distribution among dementia subtypes. This is a model that kind of shows how the person factor, caregiver factor, and environmental factors interact together to cause behavioral and psychological symptoms of dementia. If you start from the top right, neurodegenerative process itself can lead to behavioral and psychological symptoms of dementia. And also neurodegenerative process can change a person's ability to interact with the environment and interact with the others. And there can be other factors in the patient. For example, there can be premorbid personality traits. There can be past psychiatric illnesses like schizophrenia, and for which they may be on treatment. And there can be medical conditions, especially this patient group has a lot of undetected medical conditions which can complicate this picture. And because their communication may be impaired, understanding as well as expression can be impaired, and they may not be able to communicate their needs to the carers. Like they may be in pain, they may be having sleep issues, they may be having anxiety issues, or they may be bored without, no activities to do during the daytime. So these may be unmet needs, and they can be expressed as certain behavioral problems. Then caregiver factors, stress, burden, depression, and lack of education, lack of understanding about the symptoms of dementia. And there are problems in communication, mismatch in expectations about what are the problems expected in certain stages of dementia. All these things can lead to problems in manifestation of BPSD in the patient, as well as the carer's coping ability. Then there are environmental factors. The patient may have a overstimulating or understimulating environment. There may be safety concerns. The structure to the day or daily routines may be disturbed, and these can eventually lead to BPSD. The same model can be used to actually investigate and manage behavioral and psychological symptoms of dementia. In the assessment, we take collateral information usually from the bystander, and we want a clear description of the behavior, as well as we want to interview or examine the patient himself or herself, do physical examination, investigations, and then carry out a mental state examination, as well as to look at their medication charts, and can use scales like neuropsychiatric inventory if you need to quantify these symptoms. By breaking down BPSDs into ABC charts, can actually help us understand this behavior clearly. If you look at this ABC chart, ABC is A for antecedent, B for behavior, which is problematic, C is for consequence. If you look at this chart, you can see this person, this is 3 different days. This person, around this 11 a.m., 10:30 a.m., he is generally alone, understimulated, and this is followed by some behavioral issues. And inadvertently, his behavior is rewarded by the attention of the wife or some other family member. And if you look at this pattern, this man's behavior is not going to get better, and no amount of antipsychotics or other medications might help him. But by understanding this behavior, you can change the behavior by either changing the antecedent, that is, by engaging him better, or by changing the consequences, that is, not rewarding, not giving attention to the undesired behavior. So that is one example of how ABC chart can be used to assess a certain behavior. Most of the best practice guidelines consistently promote non-pharmacological interventions for the management of BPSDs. They are safer they are effective. We know that especially things like caregiver training are very effective with the effect size even more than antipsychotics for aggression or acetylcholinesterase inhibitors for cognitive improvement. And we also know psychotropics can't be the answer for everything. I mean, sometimes some behavioral problems don't respond to medication, like refusal of care, shadowing or following the carer, or wandering, repetitive vocalizations. They don't respond very well to medications. There are some concerns for non-pharmacological interventions too. Occasionally, a person might get agitated or aggressive. Things like aromatherapy might have certain side effects. So there are side effects, but they are much less when compared to antipsychotics or psychotropics used in the condition. When we talk about non-pharmacological strategies, we talk about strategies that target the patient and the carer and the environment. Non-pharmacological interventions targeting the patient. Let's take sensory stimulation type interventions. There are music therapy, aromatherapy, bright light therapy, massage or touch, white noise, snooze-a-lern. There are so many therapies based on sensory stimulation. Out of the lot, music therapy has good evidence to show it is helpful in aggressive behaviors in institutionalized patients. Rest don't have, unfortunately, a lot of evidence. When it comes to behavioral management strategies, differential reinforcement stimulus control is one method, like I described in that ABC chart. By reinforcing the desired behavior, not reinforcing the undesired behavior, can lead to extinction of the undesired behavior. Then social contacts, one-to-one interactions, pet therapy are used. I don't think there's a lot of evidence, but they are generally felt to be helpful and liked by the patients. Other therapies like person-centered care, that is, interventions are actually based upon the patient's own preferences, needs, their abilities, and that are supposed to be more helpful when compared to generic therapies given to everybody. There's a new concept called dementia care mapping, which is observing the dementia patient by a dedicated observer over a day or two very closely and understand the issues the patient may be undergoing, and based on that, making changes to the environment or caregiving arrangements. Exercise, environmental modifications, and caregiver education can also come here. Let's look at interventions for family caregivers. This has the best, strongest evidence in managing BPSD. Significant reductions in caregiver upset, negative communications, frequency of behavior symptoms, and improvement in functional dependence could be seen. These interventions mostly involve education and support to identify potential triggers and address problem behaviors, problem-solving skills, and education and training to identify care recipients' strengths and weaknesses and plan activities, and help communication, reducing the complexity of the environment and also simplifying the tasks for the person to carry out with dementia. And also these activities look at stress reduction techniques for the caregiver. Environmental approaches, they also have a good, reasonable evidence base to say that these interventions, environmental approaches, help situations like wandering and agitation. Evidence for improvement in a wide range of outcomes like overall well-being, activity engagement, and elopement behaviors, that is, trying to leave the care home or patient's own home by various environmental interventions, and acceptance of care. These environmental approaches usually accept safety measures, reduce access to harm, like unprotected gas cookers or various poisonous substances or sharp materials at home, or it can create a nice activity schedule or a daily structure and encourage adherence to familiar routines rather than routines changing very frequently, and ensuring appropriate level of stimulation. By doing so, these activities can be quite helpful. Then using the psychotropics in managing BPSD, psychotropics play an important role, but it has a limited role due to a lot of side effects and inefficiency in some of the BPSDs. Should be used only if there is a risk of harm to the patient or others, and only when other more reversible causes like a UTI or a delirium is excluded and addressed, and when non-pharmacological interventions were proven inadequate. Under those circumstances, often psychotropics can be used. Three exceptions would be major depression, psychosis, and aggression. Usually used via oral route in the lowest possible dose, as mentioned by the previous speaker, and it should be monitored very closely, and we need to know the baseline investigations, as well as if we are continuing it for any length of time, we might need to monitor at regular intervals. And should be in conjunction with non-pharmacological measures. In dementia, the use of first and second generation antipsychotics have a black box warning. That is to say, both first generation antipsychotics and second generation antipsychotics can cause sudden cardiac death, increase mortality, increase cerebrovascular accidents, and cause a lot of other side effects. Therefore, they need to be used very carefully, especially if there are a history of stroke, hypertension, diabetes, atrial fibrillation, smoking. When there are risk factors, this risk can be worse. So delusions and hallucinations can be common in dementias. So let's look at this particular BPSD. Delusions in Alzheimer's disease, however, or delusions in any kind of dementia, are usually secondary. The primary pathology is amnesia. Usually, these delusions can be understandable by the person's own experiences or interpretations. For example, a mislaying purse might lead to the delirium might lead to the secondary delusion of theft. These delusions have a distinct flavor, distinguishing them from delusions of functional illness like in schizophrenia. They are less complex, often involves intruders coming into the house or theft, and sometimes very often misidentification syndromes. Hallucinations, however, are slightly less common than delusions in dementia. Hallucinations are more often seen in Alzheimer's dementia and Lewy body dementia, more common in Lewy body dementia. And when hallucinations are present, visual hallucinations are the commonest form. And out of interest, I like to show this slide. This is misidentification syndrome seen in dementia. Capgras delusion is when a familiar person, when an affected person believes a familiar person is replaced by an identical imposter. They can recognize the person's face as husband's face or a sibling's face, but they don't get that familiar feeling with that face. There's a mismatch, and this mismatch leads to the delusion that this known person is replaced by an identical imposter, can lead to aggression in some occasions. Frigoli syndrome is the opposite. A person believes an unfamiliar person is actually a known person. They feel a familiarity in the presence of an unknown person. Then phantom border syndrome is when someone uninvited is believed to be living in the patient's home. Then TV sign misidentification, even on television, events on television perceived as occurring in external three-dimensional space. Nurturing syndrome, that is, deceased family members are believed to be still living, and patients tend to look after them, care for them. Reduplicative paramnesia is the belief that a place has been duplicated and existing in another location or two locations. Likewise, there are several misidentification syndromes. How to manage psychotic features in dementia? We talked about principles of prescribing any psychotropics. Based on that, also the risks and benefits need to be assessed by the clinician and discussed with the patient and the family. Need to discuss these things can happen, but benefits need to be more immediate or more valued for you to take that risk and go ahead with that prescription. For mild to moderate symptoms, consider using acetylcholinesterase inhibitors or memantine, especially Alzheimer's and Lewy body dementias. If symptoms are persistent, severe, or causing harm, then a careful trial of antipsychotics can be used. Commonest would be risperidone 0.5 milligram twice daily. It's licensed up to about 1 milligram twice daily. That is the only medication licensed in the UK. Other medications are also used but need to exert caution. Olanzapine is another one. In Lewy body dementia, they're very sensitive to antipsychotics. They can have fatal sensitivity reactions to antipsychotics. Therefore, it has to be with, only in essential circumstances can use quetiapine or clozapine, two drugs that has minimum extrapyramidal side effects. Usually, if there's no response, no point continuing, need to withdraw, taper and withdraw, review side effects versus benefits, and you will continue it only if the benefits are better. After an adequate response, even when the patient's psychotic features get better, you should not continue it forever. You need to review, try to reduce at 6 weeks, 3 months, 6 months. If the symptoms do not return, you can gradually stop it. If symptoms return, unfortunately, you might have to continue it for longer, knowing all the risks. Not pharmacological interventions of psychotic features. Avoid direct disagreement. Even when the person is accusing you or very distressed, avoid getting upset, remain calm, reassure the person that patient is safe, make the patient feeling calm and comfortable. Once reassured, then you can distract and redirect to get him to engage in a more enjoyable activity. Treating sensory deficits may be helpful in preventing, especially visual hallucinations and misidentification syndromes. Agitation management is very similar. There are a lot of forms of agitation: aggression, wandering, purposeless hyperactivity, rummaging in drawers, repeatedly putting on clothes or taking off them. So they usually tend to get worse with progression of dementia. So again, explore the possibilities of other things, other conditions like delirium or pain causing this, and address that as an initial step, and then use psychosocial environmental interventions like discussed before, and only offer antipsychotics if they are at risk. Agents that can be used would be risperidone, aripiprazole, olanzapine. Sometimes we use quetiapine, and they seem to be helpful in severe agitation and aggression. Use the lowest effective dose, and as I said, regularly review and stop. There can be other pharmacological interventions, especially for Lewy body dementia. You need to avoid, whenever possible, prescription of antipsychotics, but can use donepezil in mild to moderate dementia, or in conjunction with memantine, donepezil and memantine, moderate to severe disease. Antidepressants may help decrease agitation, especially when agitation has occurred in the context of depression or anxiety. Agents would be citalopram, sertraline, and mirtazapine. Benzodiazepines need to be avoided due to risk of falls, sedation. Occasionally, we tend to use though. Evidence for analgesics are there, especially if the pain works as an unmet need. Use of analgesia might be helpful. Stepwise treatment protocols can be used. Aggression non-pharmacological interventions is again to identify the triggers and identify the underlying emotion for the aggression. It might be the fear, it might be discomfort, it might be the hunger or thirst, then good communication, listening, reassurance, eye contact. This can be helpful. Calming body language, calming touch language need to be used, and it is unhelpful to restrain them. And once calmed down, then use distraction and redirection to personalized activities that promote engagement, pleasure, and interests. Music therapy is helpful in this. I want to present this model, and in my presentation there, this is a model that can be used for assessment as well as collaboration between patient, family member, and the clinician in managing BPSDs. It's called DICE. D is to describe the symptom. I is to investigate what is contributing. C is to everybody to get together, the physician, the caregiver, the MDT, and rarely the patient might join, get together and talk about or create methods to address the issue at hand. This could be, if it is overstimulation in the environment, this could be reducing the number of people coming, reducing the noise, so on and so forth, and then evaluate. Mood symptoms and anxiety are quite common. As I said, pharmacotherapy involves, for mild to moderate depression in mild to moderate dementia, usually it is not recommended, although we generally practice it. But for moderate to severe depression, antidepressants are indicated. SSRIs are the obvious choice. Sertraline and citalopram are the most used. Apathy becomes worse with the progression, and they lose the motivation, drive, and goal-directed behavior. And activity scheduling might be helpful. Sleep, day-night reversal is quite common, and the nice recommendation is to consider a personalized multi-component sleep management approach that includes sleep hygiene, education, exposure to daylight, exercise, and personalized activities. Promethazine can be used, but again, benzodiazepine need to be avoided. Impact, this is the most complex, stressful, and costly aspect of dementia care. There are risks involved to the patient, staff, carers, and the sufferers themselves. And there's potential for long-term abuse and neglect if appropriate services are not provided, and need specialized residential and nursing care facilities. And poor patient and care outcomes. Poor patient outcomes include excess morbidity, mortality, hospital stays, and early placement. And finally, the poor care outcomes will be stress, depression. Up to about 85% of depression could be seen among carers, and their income is reduced, low quality of life. So thank you very much for this opportunity to present about BPSDs.
Thank you for that very comprehensive lecture on recognizing BPS in a patient with dementia, and also the ABC approach to assess undesired behaviors and the management using the DICE approach. We have no questions to take up. Thank you once again, and we will be presenting an e-certificate of appreciation, and you will receive it in due course. Thank you. We want to remind you again, you could post your questions on the Q&A, and we will take up these questions at the end of each lecture. Our third speaker is Dr. Udayangani Ramadasa. So end-of-life care is another important aspect, and the management of geriatric patients in their last days could be a challenge. She will be speaking to us on managing the last days of life of frail elderly. She is a specialist in internal medicine and also a member of Board of Study in Medicine, Geriatric Medicine, and Palliative Medicine of the PGIM. Over to you, Dr. Udayangani. Thank you.
Thank you very much. First of all, I would like to thank the Ceylon College of Physicians for inviting all of us for this specialty update. And this lecture, I would mainly concentrate only on the last days of life of frail elderly. So if a patient is diagnosed to have palliative, it means life-threatening. So by the time of the diagnosis, we need to concentrate about optimizing quality of life using palliative approach, as well as maximizing community support. And if you think that the patient is now actively deteriorating and the patient would have only weeks or months, nearly less than 1 year of life, that period, last 1 year of life, we call as end of life period. And the last days of life, by the time the patient is started actively dying, so that is the period we call as terminal phase. So this talk is mainly concentrating on the last days or hours of care of a dying elderly patient. So when we have a patient who has multiple problems, medical problems as well as other comorbidities, diagnosis of dying and predicting prognosis is very important. It is very complex as well as challenging. And it has numerous physical, biological, psychological factors. So when we want to diagnose dying, we have to have an understanding of the performance status of the patient, how the patient performance status deteriorated over past few months or weeks of life, and the disease trajectory. If the patient is having underlying comorbidity, what could be the natural trajectory of those diseases and how it has affected this patient, and the symptom burden. What are the symptoms and the symptom burden, and how the symptoms are being responding for whatever our management. So, and so that is a patient whom that we have, we are familiar with, and we can actually, it would be easier for us to diagnose dying. But there would be patients who come suddenly to the emergency department, and we can take the history from the relatives, but the serum albumin level is used as a one measure to diagnose that the patient has significant deterioration of physical health. So when we predict prognosis and diagnosis of dying, I said it is very important that we should have an idea of the natural trajectory of the illness. So this first one is actually the frail elderly patients. We know they anyway functionally decline over a period of time with whatever the stresses like infection or inflammation or delirium or any other falls or any other insult. There would be deteriorations. Either one of this deterioration, the patient has a chance that they might end up with death. But however, if you look at the history, once they functionally significantly deteriorated, during that period, if they face with whatever these insults, there's a very high chance that the patient would die. And if they have organ failures like COPD, heart failure, liver failure, renal failure, liver, those also there can be exacerbations and remissions, but invariably the death, there is uncertainty that the patient might die in this period, but and if you notice that there's a significant accelerated frailty phase after this admission, after going home from this admission, after we know that the next admission we will not be able to save the life. So that is how we predict the prognosis and diagnose dying. So for somebody to a healthcare professional to diagnose dying, they should have a very good knowledge on the natural history of the illness, as well as they should have skills in identifying these important aspects. And there are barriers to diagnose dying. So we know that most of the time, as healthcare professionals, most of us actually, we don't think about dying, and we try to escalate whatever the management that we can offer to these patients. So we always have the hope of patient might get better. When we don't have a definitive diagnosis, when we have unrealistic hopes about the patient, and when there's unrealistic hope about the patient in the relatives or the relatives, so when there is a disagreement about the patient condition and lack of knowledge on how to manage symptoms, we always just concentrate on the numbers of the investigation and the numbers of the oxygen saturation and the and other investigation findings. And when we are having lack of skills in communication, for example, like in like a patient would develop a cardiac arrest during the visiting hours. We all know that the house officers and junior staff members have very poor communication skills, and they don't know how to face, and they start with pseudo resuscitation and all those things. So there are a whole lot of things that we need to improve when we actually want to give a proper care for a patient who is dying. So men fear death as children fear the dark. And as that natural fear in children, we need to prepare our patients. We all have fear of death. We don't know what will happen, what is the death like, and what would be the what will happen after the death. So it's a natural thing that we have fear, and it will increase the fear if we don't prepare these patients to face this occurrence. So the care at the terminal phase is important for the patient, as well as especially for the family members, because the way the patient, their loved one, is being died, has a major effect on their bereavement, and that will echo down the years the way they view death. So it's very important to have a proper advanced care, anticipatory care plan, and to diagnose the end of life period as well as the terminal phase. So there are 4 types of indicators for approaching death as perceived by Lindley Davis in 1991. One is sociological, when the patient withdraws from social interaction and distances him or herself, and psychic, when the individual accepts that the death is imminent and the retreat into himself, herself. So most of these patients actually, we know that they accept, they know that they have come to the end. And biologic, resulting in reduced level of consciousness, and the physiologic, the vital organs start deteriorating. It will no longer operate effectively. So generally what we see is the decreasing in performance, status and function, increased weight loss and frailty, increase in need for support with activities of daily living, increasing and unstable symptom burden, decrease in response to therapies, decrease in reversibility. These are the general signs of deterioration. And confused, they stop eating and drinking, they will have difficulty swallowing, reduced urine output, cessation of bowel movements, they might have developed death rattles, they might develop terminal agitation, and the breathing pattern might change. So what are the elements of quality end of life care? This is according to the support study. There they have identified the care related to symptom and personal care, pain and other symptom management such as nausea, vomiting, breathlessness, and the breathing being prepared for death. It's very important for the patient to be prepared for the death as well as for the family members to be prepared for the death. And the communication and anticipatory care planning is very important in this, the prognostication skills of the healthcare workers. Achieving a sense of completion. So we all want to, if we have done something, we all want to complete whatever the work that we have done. So life is also like the same. So we want to complete, we want to feel that I have completed my life. So we have to allow them to say goodbye, and we have to allow them to finish their businesses before they leave. Being treated as a whole person. So it is not just a disease organ that we are dealing with. So we have to maintain the dignity of the patient. We should know until the last moment, they still have cognition, volition, communication and communication, giving and receiving love. They should not die alone. We have to have the sense of humor with us, and we have to listen to whatever they want to contribute to others. Relating to family, social and care providers, trust and comfort with clinicians and nurses, being able to help others. So we address their spiritual distress and spiritual or religious beliefs, and it should be consistent with their cultural and ethical beliefs. So to offer, to allow the patient to have a good death, what are the things? What are the things that we have to develop ourselves? So we should be able to communicate openly. So regarding the symptom control, treatment decisions, place of ongoing care, place of death, and the honest prognostication. So we know that it is not like in cancer patient, in non-cancer patient and frail elderly. Sometimes even though we think that they die, they might recover with whatever the management then you have. So there is some kind of uncertainty, but still we should discuss about the prognostication. And we have to very much concentrate on the physical symptom control, such as pain, nausea, vomiting, anorexia. I have seen a lot of elderly patients, they are suffering due to the constipation, loss of appetite, abdominal discomfort, and because of the constipation, they become delirious, and sometimes they might develop infections, urinary tract infection. So cough, delirium, dysphagia, all these things we need to attend. And then what is this good death? So we all know that there are no right way or wrong way to die unless we deliberately self ourselves harm, right? So the studies have found that the six major components: pain and symptom management, as we discussed, clear decision making, preparation for death, completion of life, contribution to others. They might want to contribute something to others, and affirmation of a whole person. So everything that we have actually discussed has found in the literature that these are the main component of good death. So, and ultimately, it has defined as free from avoidable distress and sufferings of patients, families, and caregivers, and reasonably consistent with clinical, cultural, and ethical standards. So, in 1960s, actually, it was thought that the cause awareness, if the patient doesn't know that the patient is going to die, that would be the best way to die. But in 1990 and 2000 has found that we should tell the patient, because otherwise it would be incomplete death for the patient, incomplete exercise for the patient. And patient themselves has autonomy, and they want to put their personal things in order, and they want to prepare their family for the future. They want not to be burdened to the family, and they want to plan their own funeral. So and in fact, most of the time that we have seen in our patients, most of the relatives actually doesn't want us to tell the diagnosis, but the patient is very, very distressed, and patient is not being given any chance to discuss or open up whatever the stresses that they have, because they always ignore and they always change the discussion to a different aspect. That is because of the poor ability of communication of all of us. And ultimately, patient will suffer. Patient become more and more isolated and helpless, and the patient will suffer. And Dr. Chaminda Pereira, one of our ENT surgeon, has done a study with cancer patient in Anuradhapura and has found that 94% of our Sri Lankan population patient actually wants to know the diagnosis. But we assume that culturally, we assume and believe that it would be always better the cause awareness rather than the patient knowing the diagnosis. So, and we need to discuss about the place of death, where we should honor the patient preferences. We all know that if we go even if we travel foreign country and after coming back, how we feel comfortable when we come back, be with your family members and in your own home, own bed, own room with own clothes. So we should honor the patient preferences. Sometimes patient might prefer hospital, nursing home, or other healthcare facility as well. And if it is dying at home, we have to give a good quality death with greater family satisfaction. And we should empower the family members how to look after a dying patient at home. So there are practical, emotional, as well as social, psychological, all these factors, how these affect and what are their role in caring a dying patient at home and then dying in the hospital. So we always should maximally allow the family members to be with the patient in a place where they have privacy, and around the patient always prefer to die around their loved ones. So with very good symptom control, whatever the distressing symptoms, we should control, maintaining at maximum lucidity to communicate with their loved ones. So this is the time period that actually we need to discuss about the ICU care, whether the patient would need ICU care, whether the patient feel what are the measure, how are we going to give care, what are the indications of antibiotic and other sophisticated care in ventilation, NG tube, feeding, and all these things we need to discuss well beforehand. We have to plan a very clear, relaxed, sound, and a comfortable ending with dignity to all our patients. So what are the common symptoms at terminal phase? They might become drowsy. So always let the family members to visit the patient and communicate with the patient when they are more alert. And becoming unresponsive, they might become more and more unresponsive, but we have to explain the family members that the patient can hear, as well as definitely they will hear the touch, they will feel the touch. So ask them to be with the patient and how to talk to the patient and how to say thank you as well as goodbye to the patient. And confusion about time, place, identity of loved ones. So they might become delirious, they might become confused. So then the loved one, the family members might get little distressed. And in fact, the nursing staff and other healthcare workers also might be questions time to time regarding this change of the patient. So we, as in the previous talk, so we will, even at the terminal phase, still gently we should try to remind the patient the time, date, and the surrounding people who are there. And they might be having loss of appetite. So rather than loss of appetite, what they feel is actually they have decreased interest in food, because food and fluid, because their body is anyway shutting down. So because of that, we can give whatever the patient would like to eat or drink, or the things that patient can swallow. And the ice chips and water jelly may refresh the patient's mouth and the feeling of swallowing. So those are the things that we can do. Loss of bowel and bladder control. We have to keep the loved one clean, dry, comfortable. So you can use either disposable pads, or if there are wounds around and if there are bed sores and anything, you might consider indwelling catheter. So skin will start becoming cool. So warm them with the blanket and explain all these changes to the patient's relatives as well. And the breathing start regular, shallow, and noisy. So rather than panic on those things, looking at the oxygen saturation and trying to give oxygen and may see CPAP, BiPAP, or any other ventilation support. So we have to position the patient, place the patient in a comfortable position, and be with the patient and concentrate on the other care rather than physical, these numbers, as I said before. And then this is one of the common questions we are being asked. Am I going to starve death? And the relatives might ask whether my mother or father is starving to death. So I don't want them to starve death. So what is the place of nutrition in dying phase? So it is very well established and very well studied and found that during the period of actively dying phase, at the beginning, the beginning of the dying phase, we should not consider any nutritional intervention, because it will not give any good to the patient. And in fact, terminal hypometabolism state, if you load with a number of load with food, actually it might cause excessive metabolic distress to the patient. So whatever the nutritional support is not going to lengthen the life, or if you don't give, it will not cause shortening the life. So whatever the comfortable that patient would prefer, So you can go ahead with that. And psychological distress among family members is the one which we need to tackle. So you should have a very good communication, and you have to develop trust with the family members. And it is the basically communication that we have to do, education of the family members. And but we more concentrate on the religious, ethnic, and cultural beliefs. And depending on that, we can have discussions on withdrawal or withholding of artificial nutrition in these patients. So whether the next question is whether my mother or father is feeling thirst. So we know that the terminal condition, terminal phase, the sense of thirst is blunted. So a little bit of dehydration will allow patient to become more comfortable, less distressed, become less bloated, and less death threats. And small amount of fluid, so eye chips can be given by mouth, and keep the mouth moist. That is the most important thing that you have to do. And as I said, there are beneficial effects as well by keeping little bit of dehydration, because it will melt away the swelling, and it will reduce the nausea, vomiting, bloating, and regurgitation of the patient. And it will reduce the urine output, which would be more comfortable to the patient during this period of actively last days of life. So are we really addressing physical symptoms? So when we have a patient who is terminal, we always think about the oxygen saturation, the full blood count, the hemoglobin, blood urea, creatinine, and blood gas analysis reports. So are we really addressing physical symptoms that patient is suffering? So the pain. So it is known that even though the patient doesn't have any painful underlying condition, there's a significant proportion of patient is having actually pain. There can be new pain due to the contractions and immobility, fracture, pressure sores, urinary retention, as well as the pain. Already having pain can get exacerbated. There can be little more increased pain. And for the comfort, also you might have to think about giving some pain relief. So if the patient is not responding, it is very important for us to actively look for whether this patient is pain. When you try to turn the patient here side to side, you will see, if you look at the face, you might notice we might have to give pain medications. So if the patient has not been on any opioid, actually it would be 1 to 2 milligram of morphine every 4 hourly would be the dose in elderly patient. If you think that the patient has renal impairment and the other system shutting down, so you can give 6 hourly rather than giving 4 hourly. And if the patient is actually, because these patients will stop eating and drinking, so oral opioid might not work, then the ideal would be subcutaneous route. And we don't have subcutaneous cannula and syringe drivers in Sri Lanka yet. So what we can do is we can put a abdomen, and you can inject the morphine, very small dose, every 4 to 6 hourly to keep the patient comfortable. And there are myths about opioid and sedation. So some of the people actually doesn't want to give, especially in developed countries, they are very scared if we give morphine, the patient might, it will exacerbate the death. So there is no shortened survival or hastening of death with morphine. And when they become drowsy, they attribute to that to the morphine. It's the terminal phase that the patient is actually becoming drowsy. So we need to explain these things, and we need to concentrate on the comfort of our patient rather than when we discuss with the family members and relatives. So, and then the breathlessness. So breathlessness also, if you know the cause of breathlessness, you can act on the cause. But during the very terminal phase, actually, unless patient is very hypoxemic, you can give oxygen. Otherwise, giving oxygen is not going to improve the breathlessness or dyspnea in these patients. So the drug of choice is basically, and the other measures like fan would be helpful. Upright position would be more comfortable, but the drug of choice in breathlessness management in advanced stage of breathlessness is the morphine. So that is also the morphine. You can give subcutaneous morphine 2.5 to 5 milligram, but frail elderly patient, as I said before, it would be 1 to 2 milligram every 6 to 8 hourly. We can give as for the breathlessness. If you think that the patient always breathlessness, most of the time the breathlessness is associated with anxiety, because it's a feeling that you are going to choke. So you might have to add midazolam as well. So the nausea, as I said before, intractable nausea is very uncommon, but always we need to find out whether there is any underlying cause regarding the nausea. Opioid-related nausea, gastroparesis. If it is opioid-related nausea, the drug that we have in Sri Lanka is haloperidol, 0.5 milligram we can give. And the gastroparesis, then it would be metoclopramide. If it is malignant bowel obstruction, then you have to think of glucocorticoid, opioid, tried and other medication. If it is chemotherapy-induced ondansetron. And so if you don't have any underlying diagnosis of the nausea, the ideal would be a small dose of haloperidol. You can give subcutaneously, or even if patient is still can swallow, then you can give 1 milligram oral. And the delirium. Now we discuss about the restlessness and agitation in dementia patient and frail elderly. So in dying patient, actually it's more distressing to the family members rather than to the patient, as well as it is distressing to the nursing staff, because when the patient is delirious and patient is aggressive or restless, always the family members come and complain to the nursing officers. So that is we need to discuss with the caregivers about regarding the delirium, and it is not very much distressing to the patient. We have to explain them. And these are the positive feedback that actually the relatives has said. The relatives say sometimes the hospital caused this, and it is very, very frightening. And this is not my mother anymore, because it will affect hugely on the dignity of the patient and the appearance, and when the other people come to visit the patient and the patient is completely different, so then the family members really get very, very distressed. Why doesn't he know who I am? So they are very upset, because last few days or hours of life, and they are not being recognized. So I don't understand why this. So it is very distressing to the family members. So because of that, it is very important whenever we treat and we give medications for pain as well as for the comfort as well as restlessness, we have to try as much as possible to keep the mental awareness awake as much as possible. So these are the studies which have actually found that the meaning of delirium to the family perspectives. And then the delirium can be hyperactive or hypoactive. So hyperactive delirium, they are more lethargic, and often this would be missed by the delirium is the one always people find, because it looks distressed to the patient, and the most of the time we try to restrain the patient to the bed. So when the patient is having altered level of consciousness or terminal restlessness, still we need to find out whether there are any reversible cause. Urinary retention, constipation, inadequate pain control, medication withdrawal such as opioid withdrawal, benzodiazepine, alcohol withdrawal, seizures, hyper or hypocalcemia, hyponatremia. So if we can find any treatable cause, reversible cause, we have to invariably act on that to keep the patient more comfortable. So this is in editorial of JAMA journal has said that it is essential to focus on humaneness of medicine to keep dying patient as comfortable and as awake as they and the families would like them to be, so they can make the last few hours or days life meaningful. So for a meaningful end, the awakeness is important if you can. So if the things are not going to work, they become more and more aggressive, then you might think of giving symptom control, haloperidol, or with or without midazolam subcutaneously. But the studies have found actually the delirium, whatever the antipsychotics, randomized control trial has found that they are not going to effective. So even though we give these medications, so even for respiratory secretions, actually position is very important, and reassurance of the patient, family members are more important, because all these medications not going to work. But the pain, definitely medication will work. Dyspnea, definitely the medications will work. And the next important thing is the death rattles. So the noisy breathing towards the end. So the family members feel that the imminent death and patient is really suffering. They feel that the patient is choking, drowning, but we need to explain them that the body is shutting down and the patient is not able to expel whatever the small respiratory secretions in the airways that they have. So when they breathe, that small bit of fluid will move up and down and then become this noise, which is not very uncomfortable to the patient. But there are medications that we can give hyoscine, like pyrrolium, atropine, but we should definitely avoid suction. And the most important thing is to reassure patient. As I showed before, the studies have not found that none of these medications actually work for. The most important thing is the reassurance of the relatives. And the loss of sphincter control, I told you even before. So the urinary retention can happen as well as the urinary incontinence. So both we need to, and profuse intractable diarrhea, we need to look into. So other than this physical symptom control, what else actually we can do? These are the most important thing. Keep them company. Don't burden the patient. Asking unnecessary questions, talking about a fear, sadness, and don't show your sadness in front of the patient. Let the patient go comfortably. Allow your loved ones to express their fears and death. Allow them to reminisce. And avoid withholding difficult information. Let them to expel their feelings, honor their wishes, respect the patient's needs for privacy. Reassure your loved ones that it's okay to die, because unless you give permission, it's very hard for them to go, and help them in making decisions. And say goodbye. Thank you for giving me your culture, your way of living. That even though the patient is unresponsive, talk to the patient, touch the patient, and deal with the spiritual issues. So towards the end, the patient might start thinking about life and death. So there might be discrepancies about what their beliefs that they had before. So rather than trying to explanation, giving them your explanation of death and dying and life. May empower them to understand by them their own. And the dignity is very important. So we need to respect autonomy, empower, and communication. Those are the most important thing to prefer the respect, the dignity of the patient. So and the last thing is not the least, it's the bereavement support. That is an integral part of the death and dying. So grieving after loss is normal. So we all feel sad, or we will have grief reactions after dismissing our loved ones. But there can be difficult grief in some of the family members. So it's very important us to recognize this very beginning in the illness, these kind of families, and support them to prepare them for that. And we should focus, integrate grief to the life. We know that my mother has died, my father has passed away, but we have to accept that, and we have to start back living back to our normal day-to-day life. So rather than getting over it or moving on, we have to train them to integrate grief to their life. So regarding, so I just explained about the last day, management of the last days of life. And if you go to the Sri Lanka Medical Association Palliative and End of Life Care Task Force website, you will find the palliative care manual for healthcare workers from the beginning of the diagnosis of a life-limiting illness. You know, you will understand, you will get a very good knowledge on how to manage palliative patients. And there's a practice guidelines in end of life care, which is being published again with the collaboration with the SLMA and Palliative Care Task Force. And you can actually read these books, download freely in the SLMA website. Thank you.
Thank you, Dr. Dyangani, for that informative lecture on a complex and challenging diagnosis and the patient-centered approach to the management of the elderly in their last days. We have one question that has been sent. If the patient is given only pain relief medications at the end of life care for a period of over a few months because the disease cannot be diagnosed in rare cases, would their death be sudden and not show any physical manifestations as the patient can't feel the discomfort?
Yeah, so if you think whatever the now we talk about the pain medication and you talk about the pain medication, that is morphine. So if the patient is discomfortable, if the patient has pain, whatever the pain medication that you give, actually it is not going to harm the patient. So the problem is that whether the patient will develop respiratory distress and depression, and whether the life will become shortened. So it is not, because unless if the patient with very small doses of morphine, like 2.2 milligram subcutaneous or 5 milligram oral, 2.5 to 5 milligram oral, actually it is not going to cause any respiratory depression, and it will actually further improve if the patient has breathlessness as well. So if the patient has several months, I mean, as you said, as clinicians, we should try to come to a diagnosis. But elderly patients, actually, it's purely because of the age that they are deteriorating. So what we need to concentrate on is that whether they are having any other underlying illnesses that which cause more discomfort to the patients, like urinary tract infection and severe loss of appetite due to constipation, or any risk of aspiration pneumonia. And so those kind of things that we have to concentrate more, as well as we have to think about holistic care plan. Holistic care, think about the patient's psychological aspect, social aspect, as well as spiritual aspect, completion of life, and giving love and affection, as well as talking to the patient, maintaining the patient dignity. Those are the more very important things that we need to concentrate, because I know that all elderly patients, we can't say that this is the exact reason that the patient is patient is deteriorating.
Thank you once again. We will be presenting an e-certificate of appreciation, and you will receive it in due course. So our final speaker for this session is Dr. Kishara Gunaratna, and he will talk on headache in older age. He's a senior lecturer at the Faculty of Medicine, Moratuwa. Over to you, Kishara.
Can you all see my slides? Can you all hear me?
Yes, you have to put it to the presentation mode.
Yeah.
Yeah, can.
Can I start? Or?
Yes, yes.
Yeah, okay, right. Thank you. Thank you for the introduction, and good afternoon to all the participants. And I'd like to, at the onset, thank the CC.
We can't hear
and
you.
the SLAGM for giving. Right. Sorry, you.
Yeah, now we can hear.
Thank you very much thank you for giving me this opportunity to speak to you. So I'll be speaking to you with regards to headache in older adults. Right. Okay. Okay. Right. So just a sort of preamble to the topic. Headache is the most common neurological symptom and affects nearly half of the world's population at any given time. And although the prevalence declines with age, headache remains a common neurological complaint among the elderly population. Primary headaches comprise of generally 2/3 of the headaches in the older population. What needs to be understood is that there's a higher index of suspicion for a secondary headache. There needs to be a high index of suspicion for a secondary headache disorder. And this is because it is generally as we grow older, or in the older age or older age groups, the prevalence of secondary headache disorders is 12 times as more compared to that of younger populations. So have that concept in mind. So I thought we'll discuss a few case histories, and I would like the audience to sort of participate in the poll questions. So this was a 70-year-old man who comes to the clinic for the first time with headache for 1 week. The headache is it involves the whole head and is associated with scalp tenderness. It is dull and constantly present throughout the day. There is mild photophobia associated with the headache. The headaches do not restrict the patient's daily activities. So this is the question, right? So what would be your next step in evaluation or management of this patient? The options that are given are: start on anti-migraine prophylaxis, start treatment for tension type headache, give analgesics and reassure the patient that the headache is going to resolve, or evaluate for a secondary headache. So the poll is open. You can vote for the answer. Okay, I think that should be enough time. Shall we close the poll, please? Yeah, so I think nearly 100% of y'all, or all of y'all, have actually answered as the last option. Let's see. Right. So what you said, what most people have answered is right. As in the preamble, I've suggested that any headache presenting in this age group, you need to be aware that the prevalence of secondary headaches are that much higher, and you need to basically evaluate this patient for red flag signs. And these and the red flag signs are, according to this acronym SNOOP 4, that is, you ask for any systemic symptoms, which include fever, chills, myalgia, weight loss. If there are any neurological symptoms or signs that are suggestive of any focal neurological deficit. Of course, old age is an independent risk factor all by itself. So if your age is greater than 50 years, again, it is an independent risk factor. The onset, if it is an acute in onset, where the headache comes on within seconds to less than a minute, and which is generally defined as a thunderclap headache. If you have papilledema, if your headache is positional, or the headache is triggered or precipitated by the valsalva maneuver or exertion, or if the headache is actually indeed progressive over several weeks to months, or has had a substantial change in pattern, all of which are red flag signs which you should generally would direct you to investigate for a secondary cause. And these are the common secondary causes that generally present during this period, where, for example, cerebrovascular ischemic events or strokes, intracranial hemorrhages, neoplasms, post-traumatic headache, giant cell arteritis, cardiac cephalalgia, headache attributable sleep apnea, headache due to acute glaucoma, cervicogenic headache, and medication always headache are some of the examples and the most prevalent of secondary causes during older age. I would also like to draw your attention to giant cell arteritis, which is a diagnosis often missed by even by experienced clinicians, where often patients present with unilateral headache associated with systemic symptoms such as extreme fatigue, low-grade fever, and sometimes proximal muscle pain, often misdiagnosed or often diagnosed as a primary headache. So I'd like to just highlight that particular secondary cause in at this juncture. So now we're talking about the same case, right? Or the case, not really case, but same patient. You elicit further in the history that he has had similar episodes when he was younger. His examination is normal, including his neurological examination and fundoscopy. What is the diagnosis that you would consider at this point? There are 4 options: migraine, tension type headache, cluster headache, CNS tumor. We can open the polling now. I think that should be all right. Let's close the poll. Right, so I think most of you all have actually got that right. So that's a tension type headache. So when it comes to tension type headache, it is one of the most common of primary headaches that present in the old age. age or older adults, and it can range from approximately 25 to 35%. And often these headaches start off in youth or middle age and continue on to old age. However, you should be also aware that approximately 10% of patients do have tension type headache with the onset after age 50. Generally, the headache, as you would generally expect in any type of tension type headache, is a mild to moderate headache, or with regards to severity, and its duration can range from approximately 30 minutes to even 7 days. The headaches generally do not interfere with physical activity, and sometimes improves with physical activity or exercise. Generally, the treatment is simple analgesics such as aspirin, paracetamol, non-steroidal anti-inflammatory drugs, whether it could be prescribed either alone or in combination. And there's level A evidence, or there's the highest level of evidence for these treatment options. You need to be aware that these treatment options do carry a risk of peptic ulcer disease and interactions with other comorbidities, especially when you're dealing with patients who are older and with multiple comorbidities. You need to be aware that these drugs also can have deleterious effects, especially in the elderly, and this also needs to be considered when you are prescribing these medications. Treatment with regards to prophylaxis is tricyclic antidepressants, of which amitriptyline has the highest level of evidence, a level A recommendation. However, it does have a side effect profile where the anticholinergic effects may limit its use, especially in the elderly. So this is the next case. This is a 65-year-old patient. This is a 65-year-old woman who comes to the clinic with episodes of vertigo. These episodes are associated with nausea and at times vomiting. She had 10 episodes for the last year. She also says these episodes can at times be followed by a dull headache. She also complains of an intermittent headache, which involves whole head since she was 35 years of age. These were associated with vomiting and photophobia. The headaches are now less severe and less frequent. Neurological examinations normal. The head impulse test was negative and Hall pike was negative. What is your diagnosis? The polling can open right now. Okay, we'll close the polling. So I think 100% of you all have actually suggested that this is migraine. Right, okay. Right, so you're right. So migraine is the second most common headache disorder after tension type headache, and generally has a 1-year prevalence of around 10%. What you need to know is that migraine aura without headache is very common in older patients, and sometimes especially if they involve the language center, the sensory cortex, or the visual cortex, they might be it might be difficult or challenging to differentiate these paroxysmal symptoms and signs from transient ischemic attacks or TIAs. The elderly migraines generally experience attacks of lesser severity compared to the younger counterparts, and increasing age does predispose for these migraines to be to change in character to a certain degree, where they might be more bilateral as opposed to unilateral, and more global, more of a global pain experience. Photophobia and phonophobia can be present and are most frequently accompanied, or they accompany these headaches more frequently, but they are less common compared to when the younger age group. Treatment, generally triptans, generally we have a reluctance to use triptans for abortive therapy. That is because it is contraindicated in patients with coronary artery disease or coronary vascular disease, and often we find that this age group, the prevalence of such comorbidities is that much higher. When it comes to non-steroidal anti-inflammatory drugs used as abortive therapy, again, you need to be a little cautious, especially with the increase in the risk of peptic ulcer disease and subsequent gastrointestinal bleeding, and also if they are used in conjunction with any form of anticoagulation, increases this risk of bleeding. They are also at risk of interstitial nephritis or interstitial kidney disease, and therefore we would generally use non-steroidal anti-inflammatory drugs with caution, though it can be used. Prophylaxis, again, there are a multitude of prophylactic agents, which include amitriptyline, topiramate, valproate, venlafaxine, and so on and so forth. Most could be used, but again, we need to be aware that all of these can cause problems with interaction, and they have a higher chance of side effects, and therefore you need to start low with regards to dosing, and titrate slowly, and that's important with regards to prophylaxis. Then we've got another patient who's an 86-year-old female without a significant past medical history, who presents with headache of 1 year duration. The headaches are exclusively nocturnal, never during the day, occurring each night around 12 a.m., waking the patient up and lasting approximately 2 to 3 hours. The severity of headache ranges from 4 to 7 on a scale of 1 to 10. The headaches are holocephalic. They are dull in nature, non-pulsating, without any form of radiation. The headaches generally are present on most days of the month, and neurological examination is normal. So what is the diagnosis now? So the options are migraine, tension type headache, primary hypnic headache, and giant cell arteritis. You can vote now. So we'll close the poll. Yeah, and I think most of you all have got the diagnosis, which is primary hypnic headache. What would you do next? Would you initiate migraine prophylaxis, order imaging, reassure the patient, or refer to a psychiatrist for cognitive behavior therapy? Okay, I think we can close the polling now. Most people are split between ordering imaging and reassuring the patient. Right, so let's try to answer that question. So yes, this is indeed a hypnic headache, most likely primary, but we don't really know. So hypnic headaches are generally commonly seen in the old age group, generally after age 50. On average, the onset is around 60 years of age. It's twice as common in women, and generally occurs between 2 and 4 a.m. or generally 3 hours following the onset of sleep. Generally, the attacks are would last between 15 minutes to around 4 hours. And patients would generally can even have up to 6 attacks per night, each of which are preceded by the patient going back to sleep. You need to exclude a structural lesion, and that is a must, especially if you are dealing with a hypnic headache, because it could be a secondary hypnic headache where there can be a structural lesion involving the posterior fossa. And some of the examples of posterior fossa lesions include cerebellar hemangioblastomas, and also in some cases even pituitary neoplasms also can present in such a fashion. So treatment options for this kind of headache would include caffeine at night, melatonin, and lithium. Lithium can sometimes be very, very problematic, especially when you are prescribing in the elderly or older patients, because of the possibility of lithium toxicity due to altered pharmacokinetics, especially with renal function and drug-drug interactions. These patients can have alterations in mental status, balance, or both. With regards to treatment with non-steroidal anti-inflammatory drugs, I think indomethacin can be a drug which can be used, especially in these kind of in the short term for symptomatic relief, and it can be very effective. Another differential in patients who present in a hypnic headache-like fashion is this sleep apnea headache, or often they can be misdiagnosed as hypnic headaches as well. So these occur generally in patients who have obstructive sleep apnea, and can range from 12 to 18% of this particular population. Generally, it's defined as early morning headaches, which improve with the diagnosis and treatment of patients with sleep apnea. Given the prevalence of sleep apnea, given the increasing prevalence of sleep apnea during the old age, a new early morning headache should be, the patients who present with this kind of symptom should be screened for sleep apnea. Right, another patient who's a 65-year-old man comes to the clinic with a headache involving the back of the head and frontal region for 1 month. The headache is dull and constant, frequently worse at night, wakes the individual with neck pain radiating to the occiput, generally between 2 and 5 a.m. He also complains of stiff neck, restrictions in rotation of his neck for the last 6 months. He has no comorbidities, denies systemic symptoms. His neurological examination was normal. What is the diagnosis now? So we've got 4 options: cervicogenic headache, tension type headache, migraine, hypnic headache. We can open the poll. Okay. I can close it. Right, so I think 100% have answered with the option, first option. Right, yes, absolutely. Cervicogenic headache is the answer, and it can often be mistaken for tension type headache. It's generally due to referred pain coming from the neck, and often associated with degenerative disc disease of the cervical spine or cervical spondylosis, which can cause local neck pain, tenderness, and worsening of pain with cervical motion. The treatment is of cervicogenic headache may be both acute and preventive. Treatment generally involves medications such as non-steroidal anti-inflammatory drugs, and certain procedures like occipital nerve blocks can be helpful. However, especially in the elderly, because of the problems with medication and side effects as well as interactions, we would generally prefer, if possible, to use non-pharmacological treatment options such as physical therapy for this type of headache. What you need to remember is that these patients may present without neck pain and may solely have referred pain in the head, and you need to be aware of this as well. So in conclusion, although primary causes of headache are still more prevalent in older individuals or in patients above 65 years of age, you need to look for a secondary cause because the secondary causes for headache are that much more prevalent. Secondary cause of headache, which include giant cell arteritis, which can often be missed, lesional headaches such as central nervous tumors, ischemic and hemorrhagic strokes, subdural hematomas, and medication overuse are some of the secondary causes that you generally try to screen these patients for. Primary headaches may present and is more prevalent in the older age. However, they may have atypical presentations. For example, in patients who've got migraine, they might not have the typical features of migraine. They may just have the aura, like I have alluded to before. Primary headache disorders include, but not limited to, tension type headache, migraine with or without aura, as well as heat-peak headache. And forming an appropriate treatment plan requires careful assessment of headache characteristics, known medical conditions, and current medication use. And current medication use, right? So that's all I have to talk with regards to headache in the older adult. Thank you.
Thank you, Dr. Kishara, for that interesting lecture on headache in older age. We have no questions now to take up. Thank you once again. We will be presenting an e-certificate of appreciation. Thank you. And I will now hand over the session to Professor Arosha.
I hope all of you can hear me. Thank you very much. We've come to the conclusion of a very interesting session on problems related to patients in their older age. We covered a wide range of subjects. I'm very grateful to all four speakers, Vidusha, Anuprabha, Udayangani, and Kishara. Thank you so much for covering the length and breadth of care of the elderly or geriatric medicine. I'm also very grateful to the audience which participated interactively at this session. Also, many thanks to Nalina, who makes it possible to reduce our carbon footprint by conducting these sessions online and also contribute to the national economy by using less fuel. All of us have been able to join this virtually, and I think it's a very progressive, positive step. It is not merely we are doing it for convenience, but we are actually directly contributing to lessening our carbon footprint as well as preserving fuel in this country. So thank you so much for joining online from all your places. Nalina, thank you very much. And thank you very much to the CCP staff. Look forward to the quiz of the on geriatric medicine, and you can win prizes. And next month is going to be hematology, which is going to be the concluding month for this year, or at least under the present council's tenure. So let's meet with hematology next week, and this week, this month will be followed up by the quiz on geriatric medicine. So thank you. Have a pleasant afternoon. Thank you very much. And also, thank you to Kamani Madam, the Secretary of the Association of Geriatric Medicine of Sri Lanka. Thank you.
Thank you.
Thank you.